I just want to remind you that the distal row, okay, the mid-carpal joint, if you look on the radial side, you'll see that the distal row is concave. Okay? The distal row is concave, and on the radial side, and on the ulnar side, it's convex. Okay? So we're really dealing with a joint that the articulation is like a side-lying S. Okay? So in reality, okay, most therapists will consider this same convex on concave, okay, same as the proximal row, okay, but in if you're going to work with truly biomechanically, you would, if you want to increase extension on the radial side, it's concave moving on convex, so the radial side would be to increase extension, you would do a posterior glide. And on the ulnar side, to increase extension, you would do an anterior glide. Okay? So just understand that biomechanically, that's the way it should be. Okay, if we're dealing with convex on concave, concave on convex. However, almost every time you're mobilizing a wrist, you need to mobilize in both flexion and extension. So if you do an anterior glide to increase flexion, and then a posterior glide to increase flexion, an anterior glide to increase extension, you're getting both sides anyway. Okay? So, and the question is, there have been no studies that show that you get better results by doing it 100% biomechanically correct, or if you go in both directions anyway to increase flexion or extension. Because most of the time, any therapists that have been out there for a long time have forgotten the mechanics anyway. So we're going to treat it as if it is like the proximal row, convex on concave. Okay? Even though that's not 100% correct. Yes.
So you said that to increase extension is a posterior on the radial side, and for ulnar is a anterior.
Yes.
But if we're doing that, we're also working on the opposite, you're saying.
No, what I'm saying is that almost all of the time, if somebody is coming to you with a wrist limitation, they're limited in both directions. So you're going to wind up doing an anterior and a posterior glide.
Anyways. Okay.
Anyway. So you're mobilizing it. And so the only thing is, if you were only working on anterior, if you were only working on extension, then you would probably be best if you did a posterior glide on the radial side and anterior glide on the ulnar side.
Okay.
Okay? But if you're going to be working in both directions, then just treat it as if it is same as the proximal row. Okay? All right. So, we're going to do both, okay? So, the thing is that now, what I need to do is I need to direct my forces to the mid-carpal joint, not the radiocarpal joint. So if I stabilize anteriorly, okay, and we're gonna do everything as if it were convex on concave, okay? So if I stabilize the radius and ulna and the proximal row of carpal bones, and I come down here, and so I'm gonna do an anterior glide with a little bit of a distraction, a teeny distraction, anterior glide to increase extension. And then I can take her into more extension, a little bit of a distraction, anterior glide, more extension, a little bit of a distraction, anterior glide. So now I'm doing anterior glide of the entire distal row on the proximal row, okay, to increase extension. Same as I did for the radiocarpal joint. And if I want to increase flexion, I need to do a posterior glide. So the only difference is that my hands are supporting or stabilizing the proximal row and the radius and ulna, and mobilizing the distal row. Okay, so a little distraction and increase, so I'm doing a posterior glide to increase flexion, a little more distraction, inflection. Okay. When I get to a point where my hand doesn't work well anymore, okay, I can change things around. You always want to be able to change things around. So if she has a lot of flexion, okay, you can be holding her here. And so I can create more posterior glide, okay? Okay? To increase flexion. Okay, so you need to kind of be creative about how you move yourself to accommodate the patient's ranges, okay? So that is using the distal row as if it's the same configuration as the proximal row. So if you can do that well, that will be good enough for you, yeah.
So when you're stabilizing, are you stabilizing now on the proximal row, or are you still at the radial?
No, if I'm going to mobilize the distal row, I need to stabilize the radius, distal radius, ulna, and proximal row. Yeah. You can't just stabilize the proximal row. It doesn't work that way.
So, and the common pitfall in most of the student and practical exam is that you're doing the glide without distraction. Make sure that you do your distraction while you do your glide, because that's basically the one that is going to do something for the patient.
Yeah, but the distraction, so there's distraction as a technique takes it to end range, okay? Distraction as something that goes along with the mobilization is a distraction just enough to decrease the surface tension in the joint. if I try to distract her fully and then mobilize, when I've stretched the ligaments so much that I've taken up all the slack in the joint and you can't mobilize. You know, it's like when you take your finger and you fully pull it out, okay, that's the kind of distraction that you want with distraction as a technique. But distraction to decrease the surface tension of the joint is a 1/16 of that.
16, like 16%.
Just that teeny bit of distraction so that the joints aren't like this, they're just separated a teeny bit, but not all the way. Okay? So that is the distal row, okay? Then we're gonna go on to the intercarpal joints. So so somewhere back when you were doing palpation lab and somebody asked you to palpate the lunate, you went, I know it's in the wrist, okay? Now when you palpate, you will be able to actually differentiate the lunate from the radius from the capitate, okay? So when you do intercarpal mobilizations, there are different ways to organize it. The way I organize it is I start on the radial side and I do radius and the proximal row, and then I move towards the ulnar side and I do ulna and the disc and triquetrum. Then I go back to the radius and I do the distal row relative to the proximal row on the radial side and work my way over, okay? Some people use the radius as the center of the wrist and they'll mobilize everything around the radius. But you can, as long as you know how to differentiate the bones, that's what you need, okay? So, we're gonna go on to do that. So, what we're gonna do is take a pincer grip hold between thumb and index finger, okay? On the dorsal radius and the volar radius, okay? Now, when you come off of the radius, which bone is immediately distal to the radius? Scaphoid, okay? And you remember how to make sure you're on the scaphoid?
Snuff box.
Well, your thumb can move up, but then you've got different bones. It's really ulnarly deviating, and the scaphoid comes right into your fingers. So the scaphoid is going to be right there. Okay. So I can hold the hold the radius and pincer grip the scaphoid, and I can then just do a general AP and PA of the scaphoid on the radius. Okay, and then got a little clicky here.
I feel it too.
Okay, and then if I go a little bit more to the center of the radius, so I'm on that tubercle that you thought you'd never have to hear about again, Lister's tubercle, and that's it right there. And then just distal to Lister's tubercle is the lunate, okay? So I just hold the radius at Lister's tubercle and I move the lunate anterior and posterior. Okay? And you can feel that movement is very focused right there. Okay? And then after the lunate, I got what? The triquetrum, okay, which articulates with, does it articulate with the
BC.
with the TFCC, right? So I'm moving my stabilization more towards the ulna, and then I've got my, I can do it like this if my hands are big enough, or I can come here and I can hold the ulna and the TFCC and move the triquetrum. The volar part of my hand will be on that little pisiform bone because that sits on the triquetrum, okay? So basically, I'm trying to pincer grip everything, okay? So, you're following? Okay, now we're gonna go to the mid-carpal joint. So, I find the distal radius, and I hold on to the scaphoid, and what articulates with the scaphoid at the distal row? Trapezium. So I'm gonna find the metacarpal, and I wanna be proximal to the metacarpal, first metacarpal, and then I'm actually gonna mobilize the trapezium and the trapezoid together on the scaphoid. Okay, and what's next to the trapezoid? Capitate. So then I'm gonna move ulnarly, so I'm on the lunate, and then I'm gonna mobilize the capitate on the lunate. Okay. Now, how do you know you're on the capitate? Is if you bend the wrist down as far as it'll go, the bone that sticks up is the capitate, and if you extend it, it rolls under the lunate. Okay? So you're gonna mobilize the capitate on the lunate, and what's next to the capitate?
The hamate.
The hamate, okay? So I'm going to then move my stabilizing hand onto the triquetrum and the pisiform, and find the hook of the hamate, and I'm gonna mobilize the hamate on the triquetrum and pisiform. Okay. And then the only one that's left is to mobilize the pisiform, and that is, you take the wrist, put it in slight flexion, and then find the pisiform, and then do a pincer grip on the medial lateral pisiform, and just move that little bone. Now, the reason that you need to flex the wrist is the FCU attaches to the pisiform. So if you keep the wrist in even neutral or extension, the FCU is stretched and it doesn't let the pisiform move. Okay? So, so why is it important to mobilize the pisiform? Is that it may help to release if the flexor retinaculum is tight, the flexor retinaculum also attaches to the pisiform. If the flexor retinaculum is tight, it may hold the pisiform down, and mobilizing it might help to reduce carpal tunnel syndrome. Okay? So you have the mobilization of the into flexion and extension at the midcarpal joint. You have the intercarpal movements, and you should go practice those.
Right, so before we break up on that, I want to just give you another landmark to remember, that a couple of the acronyms that you could remember, that the proximal row is a slot. So scaffold, lunate, trichotrom, so you would remember that. The other thing is that the rule of the middle finger. So middle finger, if you think about it, is that if you move up, the first bone is going to be capitate after metacarpal, and the second one is a lunate. The lunate and scaphoid are the two troublemakers at the wrist joint. So knowing that where the middle finger is, you could easily find the capitate and lunate, and the rest of the stuff, as Dr. Sofer mentioned, that could give you a great landmark on that. So remember a slot and remember the rule of middle finger. So that would be helping you with the capitate and lunate. All right, let's practice.